Welcome to the Eating Disorder Hope online conference. We are delighted to have you here. Our conference today is about anorexia, hope and healing in 2018. And our next guest will be presenting on the best practices for effective treatment of anorexia nervosa. And this presenter is Melissa O'Neill. She is the Director of Program Development at Timberline Knowles. Her role involves collaborating with others to create the vision and curriculum for all group programming offered at TK. She also clinically supervises the talented specialists who facilitate groups all over their campus. Early in her career, Melissa spent time in residential care working with children with significant trauma histories. She then ran a substance abuse intensive outpatient program, followed by several years in private practice. She also managed an IOP and a PHP program for eating disorders and mood disorders. At Timberline, she started as a primary therapist, followed by serving as a clinical lead. And with that, I would like to hand the presentation over to Melissa O'Neill.
Thanks, Jacqueline. So, lovely introduction, thank you. I'm Melissa O'Neill, and I'm here to talk about the best practices for effective treatment of anorexia nervosa. So the digital format is really accessible, and so I'm really glad to be doing that. And at the same time, I don't get to interact quite the same way with those watching. So, I typically am asking folks to think about as we start a presentation like this to what your interest is in the topic, and so we can really kind of highlight what is important to you. And digitally, I'd ask you to think about those same things as well, so that we can kind of be mindful to guide this, and as you guide and explore your learning about this really complex disease and all of the men and women that it affects. I've chosen, as Jacqueline mentioned, I've supervised IOP, PHP, and residential programs for eating disorders. And so, my interest in this population is really that I love a challenge. And for those of you who do work with anorexic patients, know that there is no greater challenge than really trying to break through this really difficult disease. I also love logic, and so I operate on that level, and so find myself connecting really frequently to those individuals struggling with anorexia, because we can all live in our heads a little bit, and have found as a clinician that I've then had the pleasure of learning so many of the therapeutic approaches that are helpful to integrating mind and body, which is ultimately kind of the effective practices we'll talk about today. And that as a clinician, those have been healing to me, and as a human being have been impactful to me as well. So I hope to share a little bit today about how and when we use these different approaches. We'll talk a little bit about the overview of anorexia, barriers and challenges to treating the disease, and best practices. So, and how we use those practices being most important. So today we'll talk a little bit, not just about what is most effective, but what is most effective in our ability to individualize for clients. So let's talk a little bit just about kind of the perceptions of anorexia. Initially, this is such an under-recognized disorder because other presenting factors are, let's be honest, in our culture, we're not in a hurry to identify people who are thin as problematic or perfectionist types as problematic. Often when I've had someone referred to my care, the teachers involved or even therapists involved really report that they're doing well. And so I've, in my career reached out to teachers and talking about kind of meal planning in schools and things like that. And teachers and school professionals are often surprised that the individual is struggling. So culturally, we're kind of working uphill in identifying anorexia amongst those who are struggling until it gets really problematic. And then when we do, and when family members start to recognize the issue, or school professionals or others, it becomes an oppositional fight. And so we switch from kind of an easy ride where people feel like this is someone who's doing really well, to professionals or family members just becoming angry and frustrated and withdrawing from the person, saying they just need to eat. And so I've worked with families for years, especially with teens struggling with anorexia, and family members, parents understandably become so angry and stuck, and I just want this person to eat. So we'll talk a little more about that. But initially, this is such a complicated disorder for that reason. We struggle to recognize it initially, and when we do recognize it, it's often become quite entrenched. So it can be difficult to treat. So let's get official here. DSM-5 diagnosis. So the DSM-5 that came out in 2013 recognized very little changes for anorexia diagnosis. Primarily, the biggest difference was that amenorrhea was removed. So the idea that to be diagnosed with anorexia, you had to be missing your period, was removed. And primarily that was because it doesn't apply to males. And for those teens who are premenstrual, which is quite common as well, so no way to know whether their onset is being delayed by the disorder or they are just not of age yet. And so that was removed from the diagnostic criteria. So officially, to qualify for anorexia, you must have a low weight. I actually see this missed quite frequently by clinicians, where they see restriction behaviors and other signs of eating disorders, and with someone who is an ideal body weight. And so that's an important characteristic of anorexia. Sometimes in the progression of the disease, we might not initially see the low weight, but important for that diagnosis later on. Of course, characteristic of anorexia is that persistent restriction. So we see that persistent restriction behavior, not a period of 1 to 2 weeks where there's a loss or some other type of issue or event going on, but persistent restriction over a significant period of time. Fear of weight gain. And so this is another point of confusion. So those issues of low weight and persistent restriction can exist in other eating disorders or actually other feeding disorders. So I've seen clients who come in with sensory issues and young individuals who may have really avoidant feeding patterns and also as a result have low weights, but don't have that fear of weight gain or any body distortions. And so that's an important combination to really know that this is anorexia that we're dealing with. And then finally, those body distortions, knowing that an individual with anorexia really looks in the mirror and sees something very different than we do when we're looking at them. And again, that's something in the long-term treatment that's so important to address. So just a few facts about anorexia, just to, again, to kind of give us the character of that. Over half of those struggling with anorexia have anxiety disorders. Previously, anorexia was really thought to be more of an anxiety disorder, and now we really recognize kind of a character all on its own, although it is really common for anxiety to exist comorbidly with the disorder. 33 to 50% have a comorbid mood disorder. So also important, so important in recognizing those anxiety disorders and mood disorders that exist alongside the anorexia in order to make sure we're treating the individual properly. 90% are female. So 2 points I want to make. A huge percentage then are female. So a huge percentage of those struggling are female. And then 10%, so 1 out of 10 are men. Men are highly underidentified in this population. It's also very difficult because connection really being at the root of the path to recovery, men are very isolated inside this disease and also inside the recovery community. So it's a really special population to be mindful of when we're treating. And then 85% develop the disorder between 13 and 18. This is so important. So there's so many things going on in adolescence that this is a disorder that is often missed. So as we talked about that uphill cultural battle in recognizing that, if we see an overweight teen, we might see someone more likely to identify problematic eating behaviors than if we see an underweight teen. So, and especially an underweight teen who's often working really hard to hide their body. So as we look at this disease and the characteristics of it, talking about overall treatment, so 46% of individuals recover, which is a really wonderful statistic, and I'm able to see those numbers daily, and it's really powerful. And then the 53% total do not fully recover. So putting those statistics together, which 33% partially recovering and 20% remaining chronically ill. And that last 20% is really difficult. So this is an all-consuming disease for an individual, for a family, and 20% of individuals, 1 in 5, only do not recover and remain chronically ill. So we are still working on that statistic as a major public health issue. A 5% mortality rate, so the deadliest of mental health disorders. This is a pretty powerful statistic and one that I frequently talk with families about when I'm engaging them in the treatment process. Now that mortality rate is actually less often by the biological complications of starvation than it is of suicide. And I think that speaks so highly not just to the comorbid mood disorders, but to how painful and torturous this disease is, that in the day-to-day it becomes so all-consuming, conflicting, and torturous that individuals 5% of the time choose to take their life. But we'll talk a little bit about treatment and how someone steps out of those patterns. And I think something we do have to name rather early in this presentation is that we've made relatively little progress in evidence-based research. So today I hope to talk about how we can combine the evidence-based practices that we know so that we're using them effectively with the population that it is most indicated for. So based on age or comorbidity and things like that. So we have a lot of research to do, and there's not quite the investment in research dollars that we see in eating disorder treatment, which again is a fight that we all as a community are continuing to fight. And we are making progress, and combining the evidence-based treatments will be incredibly important to have effective results for practitioners in your practice and for us to really fight the bigger trends with this disease. When I talk about eating disorders, in particular anorexia, I talk about it like an iceberg, and that what we see, the restriction patterns, the fluid restriction at times, body distortions, and all of the compensatory behaviors that come around that are the tip of the iceberg. And what we are addressing and looking at is really underneath. And typically, again, in our culture at large, when we talk about anorexia or eating disorders, we're really just talking about the tip of the iceberg. Eating is where we get stuck, but treating these clients isn't about the food. And so it's about attachments, avoidance, control, yearnings for connections to self, yearnings for connections to others, and fears, terrifying fears about those connections. If you've ever sat at a table or meal with someone struggling with anorexia and you can feel the emotional content, this is more than about food. So this is a complex client. We know that there are genetic and environmental components. So we have twin studies that demonstrate that there is a genetic component. Particularly, some of what has been teased out is that there's a genetic emotional sensitivity. And so I don't love the word sensitivity when we use that, but a couple years ago, I was running a parent group very regularly. And as I heard parents talk a lot about their children when they were young, and these were children all struggling with anorexia, they would talk about kind of the emotional sensitivity even from a young age, and sometimes even noticing that being different than their other children. And so there's this emotional sensitivity that an individual is learning how to manage, and learning how to manage in with food and manipulation of that food. So an environmental component. So there are many environmental components that kind of predispose risk. Some important ones are kind of an environment in which emotions are not talked about or accepted or modeled. Again, it's not giving that kind of predisposed, emotionally sensitive child an outlet to manage what is happening in their mind, body, and spirit. We also see poor emotional awareness. So we talked about anorexics often being those who are really in their head. And so when you do a mindfulness exercise often with someone in anorexia, it takes a long time to kind of get them in their mindful practice to start to identify. And when we process afterwards, you'll hear a lot of, here's what I thought. You won't hear a lot of what I noticed in my body, and you won't hear a lot of what I noticed in my feelings. And so we see this kind of emotionally over-controlled presentation that leads to very poor emotional awareness. And our anorexia can function as a way to help avoid upsetting private experiences. I think this is important to name in treatment as well, because it's important for us to recognize that this has served someone well, and they're resilient because this has been something that has served them when they needed it. So as that progresses, it's understandable that it becomes a pattern, and dealing with that pattern then takes some long-term treatment. But and finally, understanding that malnutrition then further impacts these factors. So these are some barriers to really treating someone struggling with anorexia. And so there's some preliminary research that restriction behavior over the long term can start some demyelination process of the neurons, right? So slowing down kind of that emotional impulse or thought impulse. And that becomes really a benefit of kind of some longer term starvation that also serves really as the call for reinforcing this pattern. And so reinforcing that it is more difficult to understand my emotions, and that further makes it more difficult to treat the individual. And yet that is what we want to do. So learning to treat the whole person. So a couple really important points as we start to break down effective practice. One is relationships are important. There's a high level of inhibition involved with anorexia. So again, those of you who work with anorexia know well that inhibitory reflexes really kind of glommed on. And relationships and attachment really lower that inhibition once trust is built. And so there's some evidence of interpersonal psychotherapy being effective for that reason. So taking an attachment approach to the methods that we talk about today is really powerful. I see it all the time in milieu therapy at Timberline Knowles, in that you'll have an individual who has a relationship with a staff member, and that staff member is the only one who can get them to drink water. And so those powerful relationships really become a foundation for treatment. I treated a young woman several years ago who came to us from another program, and she had struggled in that program, and they really do an outstanding job with all of the evidence-based research. And they said, you know, we've tried everything, and we are sending her to you. And so, you know, she came into the program, and I remember sitting at meals with her and just talking about her favorite books. She loved fantasy and science fiction. Was really just a likable kid. And so we spent time getting to know each other and built relationships. And over those relationships is when we had her challenging meals. And those relationships really began to make a difference in behavior. And it took all the evidence-based treatment that we were using and made it that much more powerful. A mind-body integration. So again, we talked about anorexics being in their head, so that top-down process. So learning to integrate in a top-down and bottom-up. And so there are a lot of ways that we go bottom up from body to mind rather than mind to body, but beginning to really reestablish those bidirectional pathways in the brain instead of kind of that road that they've driven for so many years, which is always top down in my thoughts. I tell my body what to think. I tell my body that we are not going to eat, or I am thirsty, or I am hungry. And then finally, acceptance strategies. So at its face, anorexia is really looking to change some of the realities about the world. You know, we need food to survive. And so just the lack of acceptance of that point that anorexia gives the individual really makes acceptance strategies, so those connected to ACT or DBT, really powerful in treating this population. So we'll review some evidence-based practices. We'll talk about family-based treatments really briefly, CBT and exposure therapy, ACT and mindfulness, as well as expressive therapy and somatic methods. And then again, really recognizing that this is then about individualizing the treatment. So who is most appropriate for what? That's really where we see the difference in how effective different modalities are, is what age groups, what comorbidities is this individual struggling with. And so we need to individualize their treatment. And inventories really like the EDI are helping us do that even further. And again, as we look forward into treatment, we'll see that even more. Just a quick review of family-based practices. So many of you are familiar with the Maudsley method, really with Locke and Lagrange creating the FBT model for us. The ideal candidates are young and are within 1 year of symptom onset. And so really we look at a specific breakdown of sessions in FBT along with 3 phases of weight restoration, then returning control to the teen or the adolescent, and then establishing a healthy adolescent identity. FBT is really kind of therapists guiding parents, and parents are taking the control back. I have seen this method be really effective with teens, especially when they're ideal candidates. And so that's the really important piece about FBT, is really looking at kind of how far into symptom onset, looking at the parent-child dyad and saying, are we a good fit here? Is there kind of, how is the strain already in the relationships, and really the buy-in from the families. So I have found that when the families are not buying in, it's a very difficult journey to really kind of take back during that weight restoration phase. And so if families are not fully committed to every meal, then it's not an effective method, and really you're not doing it by the book. Ultimately, I have seen when someone isn't a good candidate and we kind of try to half do it, I've seen it really backfire. And so again, remembering that relationships are important with anorexia. If we are burning a bridge inside that primary relationship with a parent and child, if this is not a good candidate for the treatment, then we are also kind of using a resource in a way where it is maybe not most effective. So CBT, another effective treatment for anorexia. So we talk about second wave behaviorism. So there's kind of, first wave is classic behaviorism, second wave is CBT, and then third wave is DBT and ACT, which we'll also talk about. So the difference with that second wave behaviorism is that the therapist is seen as the expert, and the interpretation of the event is the problem. And so what we target and work on is the interpretation of the event. And so you can see this be really effective with some folks in that, if pizza and interpretation of pizza is the problem, we talk about kind of the benefits of pizza. If interpreting my body as the problem, or body distortions, right? If someone is distorted and obsessive about their legs, then we might look at restructuring that thought of this, my legs carry me to my, help me hold my child or pick up my child. CBT is structured, which is extremely beneficial for patients struggling with anorexia because they love structure. And so the idea that we present coping skills in a structured way, like CBT or sometimes like DBT, is really, really powerful. So ultimately, we're looking at restructuring the thoughts about body, about food, and looking at in ways that those thoughts can be structured in a way that are more effective and more recovery focused. And then inside CBT and that second wave behaviorism model, there's exposure response prevention. Sorry about that. And so that is the exposure response prevention is, the goal isn't necessarily to decrease anxiety. And so this is something I tell someone up front as we're beginning ERP. So it is not that in the long run, you are going to have less anxiety about pizza. Now, my experience is, and some data suggests that that does happen over time, but that is not a short-term result. What we're looking to do is build more confidence that someone can eat pizza and that everything doesn't fall apart after that. The client is in charge of the exposure setup, and so the exposures that they're willing to participate in, and they're engaged in their own motivation for those exposures. So looking at how they drive that from values or other reasons why they may want to be pursuing recovery. This particular methodology is really helpful for those who are pretty motivated. So maybe folks who have really identified the struggle with their eating disorder, with anorexia, and are able to really commit to recovery. Those folks can do really well with ERP because it's a path to recovery. And if someone's already kind of pointed in that path, and I don't want to suggest that it ever feels 100% for anyone, but those who are more strongly motivated are able to engage more effectively in ERP, since they're really the one kind of driving the situation. And so you might set up exposures. Let's go back to that pizza example where, the exposure is pizza. And so as someone is exposed again and again to pizza, then they recognize that the probability that their fear about pizza, so a typical fear about pizza, is that it's going to make me fat immediately. It's going to change my body immediately. So that fear is then challenged. So I find that, again, as we talk about integrating these philosophies, so CBT and exposure response prevention, really effective for certain folks. And when integrated with ACT, can be even more effective. So I talked about how ERP is really helpful for those who are already motivated. And engaging in that motivation can be really powerful when ACT is used. So think of ACT as a possible adjunct or supplement to treatment methods that are already working and making those treatment methodologies more effective. So it can be added to other evidence-based treatment. It addresses experiential avoidance. And so really ACT would view anorexia as a way of experiential avoidance. And so what I mean by that is that ACT says that we are using restriction behaviors as a way of experiencing emotions or thoughts. And then what happens is we start to narrow our world, and that becomes even more difficult to tolerate. So we start to narrow the emotions and thoughts that we're open to experiencing, and inside that narrow vision, it becomes even more difficult to tolerate those that come in, and it becomes more and more narrow, which lines up with really the progression that we see with clients struggling with anorexia. And so this is about ways we try to change the realities in which we live, is using restriction behaviors is trying to change, again, that reality. And ACT says we have two agendas in the world. We have the control agenda and we have the mindful agenda. And ACT challenges us to notice when we're taking the control agenda. And I won't lie that I myself find myself engaging in the control agenda all of the time. And then pointing ourselves to what is the mindful agenda here. And so we address all of these things through motivation and values and purpose. And so ACT talks about our meaningful life. And so this is where it can be really important as a supplement to CBT or, other philosophies, ERP. And so really getting someone motivated. So what are they wanting to live for? I had a patient, resident, a few months ago who I asked her, and she was about 14 at the time. I asked her, what would happen if you didn't recover? And she looked at me just terrified. And so she said, well, I don't know. I would never go to school. I'd never have a boyfriend. And so immediately she tapped into this ambivalence that she had and what would be a meaningful life. And so she was able to really start to kind of imagine that meaningful life, and we engaged in that in several ways and connected that then to kind of the exposures that she was doing, her mindful practice, and other strategies for treatment. And so, and finally, kind of the overview of ACT. So we talked about CBT. We say in second wave behaviorism that we are looking at changing the thought, changing the interpretation of the event, because that is the problem. And so ACT says we change our relationships to thoughts. So that is kind of a different way of looking at things, that we are really just changing our relationships to thoughts. And this is where acceptance comes in. So ACT, again, is an acceptance strategy. Acceptance and commitment therapy is what ACT stands for. So often when I'm engaging someone in some difficult methods, right, as they begin treatment, and someone who's highly ambivalent, who's struggling with anorexia, I will go through kind of the swamp metaphor. So I want you to imagine that you are climbing a tall and beautiful mountain, and that you have been climbing for years, with your dream is reaching the peak of that mountain because you want to see the view. It's what you've dreamed of your whole life, and it's the only goal you have. So as you climb that mountain, you are nearly to the summit. And at the summit, you run into a huge swamp. It's thick and muddy and gross and smells, and you try to kind of go around it, try to see if you can kind of walk over, around, and ultimately you can't. So what do? You go through it, not because you want to, not because you like it or it's fun, but because your meaningful life is on the other side. And so the more we orient to the swamp, the treatment is the swamp, going and eating that meal, that pizza, that challenge meal, exposures, with mirrors around body distortion, that is the swamp. It is hard work. And ultimately, we have to have some concept of what's on the other side. Again, back to relationships being so important, as we help clients really get it kind of a taste of what relationships feel like, safe relationships with inside the therapeutic relationship, or with peers in treatment or outside of treatment, with family members. That safety begins to develop, and ultimately that begins to be a better picture of what their meaningful life is. And so inside acceptance strategies, we focus on acceptance of events, things that have happened in the past, in the present, limitations of the future, acceptance of the world around us. So, that maybe parents couldn't give you all that you wanted to have. Acceptance of private experiences, And then, normalizing what is familiar, an emotional response, feeling of losing power, and the difficulty of the process. So we really want to normalize all of those things. And then really, the acceptance piece is powerful, and is the commitment. So ACT, that language of commitment, is how we kind of take it really that last mile. So establishing awareness of values and commitment. So we talked about the meaningful life, and that's part of it. So really imagining, what would your life look like if you were in recovery? What would there be space for if every meal, 6 times a day, every meal and snack wasn't dedicated to spending time with your eating disorder? Establishing, so those values, we do things like values, exercises, and committed actions. And ultimately, we use the language of prioritizing commitments over urges. So as we establish an idea of what someone's meaningful life looks like, we ask them, what is your commitment? And so I'll give you an example of the individual I told you about, who, the teenager who really liked kind of science fiction and things like that. So she had a dream of wanting to write a book. And she'd begun kind of journaling, which also was this really wonderful healing and corrective experience that she had. And so we talked about kind of things that got in the way. And so she had compulsive exercise behavior that was part of her anorexia that really got in the way. And so we would talk about, what's your commitment and what's your urge, and really just balancing those things out. And in order to do that in a really defined way, we would create SMART goals. So many of you may be familiar. SMART stands for specific, measurable, achievable, reasonable, and timely. So we really want to be specific, so that when it's measurable, you also know that you've achieved it. And we want it to be achievable and reasonable, and also timely. So not something that we want to feel the benefit that we've met that goal. And that's how we create baby steps in ACT. So, maybe the committed action for today is, finishing 2 of my snacks, or sometimes as we progress, it's finishing all my meals and snacks. Perhaps it's a challenge meal. Perhaps it's staying out in the milieu or with my family if we're an outpatient, so that it's harder to engage in my exercising behavior. And then a really important piece with the language of commitment and treating those struggling with anorexia is that, for most kind of perfectionist types who are struggling with anorexia, the language of commitment does really stick with them, and they tend to really orient to commitment. And they also tend to drop out of treatment really frequently. And so one useful tip is to kind of orient from the beginning, that this idea of, we're going to, you may want to drop out of treatment at some point. And all I'm asking that you do is come to my office for one final session, and before you do that. And so, again, some research in radically open DBT, which is another emerging kind of treatment strategy, is that this is an effective strategy in the tremendously high dropout rate in those struggling with anorexia. So that language of commitment that really kind of comes in with the ACT philosophy is incredibly helpful. So finally, I want to talk about expressive therapies, and we talked about expressive and somatic therapies. Again, just another way to integrate effective treatment. So this is something we believe pretty deeply in at Timberline Knowles, and the idea that we have embodiment in practice. And so this is experiencing my body in a different way, other than the distortions, other than how I feel when I'm full or not full, or purging or not purging. But that I experience my body in a different way. And it works towards those goals we talked about, which is reestablishing bidirectional pathways in the brain. And then attaining an integrated sense of self. So that is when we are learning to integrate, that being able to experience my feelings and move a feeling. So in dance movement therapy, we might have somebody move the feeling of fear. We might have them move the feeling of fullness, because it's a nonverbal way to talk about it. And so the verbal pathways in the brain are really worn, right, and really practiced, and they're really attached to really kind of looking at it through anorexia. And when we start to kind of work outside of that through art, through yoga, through dance movement therapy, we're able to kind of be a little objective with it and also really help someone experience it in a different way. Not through kind of the verbal methods that really have always looked a certain way. And finally, we integrate mindfulness through all of this. So I put this picture here of my little guy because it just makes me smile. And because I know that mindfulness is really what helps us engage in these type of moments. And so when I talk about mindfulness to clients or to professionals, most people have heard the word, and really engaging in what the meaning is of mindfulness and how we do that. And so if I am not being mindful, I would have missed this moment. Now, I took a picture of it, so that also kind of takes a little bit away from being in the present moment. And if I'm obsessing about my body or food or other things, then I am not in this moment with this little penguin guy here. So one of my favorite definitions of mindfulness is waking up from automatic behaviors to participate and be present in our lives. And so that really is just a way that we are able to be in the moment. And so that's how we work on refeeding and nourishing inside treating someone who's struggling with anorexia. And it's also kind of that meaningful life part. And how do we really enjoy the moment? And what are we missing when we're not in the moment? Just like that teen who I asked, what happens if you never recover, right? And so, she thought about having a boyfriend and all of these moments that she knew would bring her joy, and being mindful in those moments, she would not be able to do that. So as we teach someone to practice mindfulness, we, are teaching them to learn to be at the riverbank of their thoughts and feelings. Most anorexics are very stepped back, or have taken several steps back from the riverbank. And so we're really trying to teach them to build awareness. And so again, as I talked about, when you typically start doing some mindful work with those struggling with anorexia, what you will notice is that they are, again, really mindful of thoughts, and the thoughts are really kind of more their eating disorder thoughts than kind of their own, if you will, and not as aware of emotions. And so as we start mindfulness, we start building on body sensations, and then we build to emotional sensations. And then we are working on teaching someone with much regular practice to learn to be at that riverbank of their thoughts and feelings. And so for most people who are kind of stepped back from the river, there are points in their lives where they can't be. And if they don't know how to be at the river bank, then they end up in the river. And so that's a huge motivator when I kind of talk through, the idea of mindful practice is that we don't have to ever end up in the river. And so you're not going to be carried away by the tides. But most people who are struggling with anorexia have experienced that. Remember, kind of very emotionally sensitive individuals who have learned to kind of control those emotions, because it's been really scary in the past to be in kind of that flooded river. So again, other mindful metaphors as we teach someone watching your thoughts and feelings as though you're watching a movie, and watching cars go by from a sidewalk bench. And so that's more kind of into the process. So no matter whether you're using CBT or exposure response prevention or even FBT, mindfulness and expressive therapies are a really important component for anyone, for any age. And you'll see some resistance about this. And so, including mindfulness or other components, remembering ACT is a really powerful vehicle as well to get people involved and motivated to try different things, right? Because most people, when I see them have tried lots of things. And so kind of breaking through that with some ACT strategies can be really helpful, and then getting them on board with practicing mindfulness regularly, because awareness and objective distance, which is kind of the mindful combination, is the really powerful piece that is important in recovery. So building awareness about what's really going on, and also having that objective distance, not too distant. Again, we can't have awareness if we're too distant. But ultimately, that goal of having kind of both awareness and a little bit of distance also allows someone to experience their emotions in a more effective way, and it begins to allow them to challenge then the eating disorder behavior. So that is the summary of all of the effective treatment strategies that I have for you today. I know we had talked a little bit about potentially having kind of a Q&A, so Jacqueline had talked about that.
Thank you for an excellent presentation. I was riveted. Really impressive knowledge, and ACT is so exciting to learn about as a clinician, and also I think just for any of the individual sufferers attending or family members too, that one, and DBT. You did a great job covering.
Thank you.
So a couple of questions are, could you elaborate on the distinction between full recovery and partial recovery, and what criteria differentiates them?
Yeah, that's a great question. So a lot of times what we'll see with full recovery versus partial recovery is someone who's begun to really address some behaviors and not others. So perhaps someone who's really had some excessive exercising behaviors, other things of that nature, and they may have even had some longer periods of weight restoration, but perhaps the body distortions and other distortions and obsessions are still really present. So in the DSM, what really is differentiating that kind of partial versus, full remission, typically, they'll do that based on level of restriction, behaviors, and body weight. Now, what I've experienced is that those who are struggling with kind of the distortions, you will see that those distortions are still coming up, and someone's responding differently to them. So that's kind of from like a therapist angle, that's really how I see the difference between that partial and full remission.
It's really helpful, thank you. Another question we had posed was, components of ACT sound very similar to DBT. How have you used ACT to augment DBT, or can you give us an example?
Yeah, that's a great question. So at Timberline, we actually utilize contextualized DBT. So Dr. Paul Holmes out of the University of Chicago has really kind of pioneered, and he will tell you that ACT is the meta under DBT. And so DBT being, Marshall Linehan created just a beautiful model for us, and DBT is really kind of the skills. It's very specific, and that's why a lot of people like it. It's why a lot of people don't like it too, but it's very useful to clinicians in that way. And ACT is really kind of, again, that meta, it's the big picture. And so, we use them a lot in conjunction. And so I would kind of talk about even just that idea of like prioritizing your commitments over your urges. So how we do that with skills is really a DBT method. And why we do that is we engage that person with ACT. So ACT really kind of helps get someone on board. It's kind of the big picture. Like DBT, they're really similar in that they love analogies. I love presenting on both of them because they're just kind of very, very real and relatable. I find that teens relate to both of them very well because, you're using kind of experientials I'll do with the teenagers and things like that. So, but we use them in conjunction all of the time. ACT is about kind of getting someone on board. And so, the ideas of commitments and, recognizing the control agenda is showing up, and we want the mindful agenda. And then DBT is really about, okay, so now I've decided I want to try to tolerate this moment without behaviors. Now, how do I do that? So now I've got my distress tolerance skills and my emotion regulation skills, things like that.
Excellent, thank you. So another question, it appears to be from a parent, about how to implement these types of skills in sort of a preventative way when they're concerned their child seems to have personality traits for an eating disorder.
Yeah, that's a great question. So, I think I use ACT in my day-to-day. I, use it with my own kids in just the idea that, accepting the realities around us, things that we can't change. So validating that it makes sense that, I wish that school would let me do X, Y, and Z. And also, that's not the reality that I'm facing. So how can I be effective in that moment? What I always say to parents is that, DBT is about acceptance and change, and ACT, again, being so related. And I find that most of us as individuals, but especially as parents, most of us gravitate more to acceptance or change. And so kind of the big picture with it is that each of us is learning to bring in the one that we're not as comfortable with. So some parents are really, okay, you got to be like, let's talk about, how we can make that into an A and how we can fix that. And, that kind of change-oriented focus. And then other parents are, I love you no matter what, and we're going to get through this. And that's where they focus, and that's more natural. So DBT and ACT talk about the fact that we need both. And so parents, getting to know the style that they tend to gravitate towards and trying to be more intentional about bringing in the other style. And so that can be really powerful with emerging eating disorders or personality disorder traits, because it really kind of helps model the balance and also kind of contain the balance. And I don't want to say balance because doesn't really represent the dialectic, but the both and. So both acceptance and change.
Excellent, thank you, very good. Another question is, how do I work with a difficult teenager to go into inpatient treatment?
Yeah, I think that decision is so, and again, if this individual is really struggling with anorexia, I think one of the challenges is that the kind of cognitive deficits we see when kind of nourishment is at the level. So I just kind of want to validate, someone who's working with someone who usually, when someone needs an inpatient level of care, usually we're looking at some really serious fluid restriction, some really serious malnourishment or exercise compulsion leading to malnourishment, and the individual's cognitive capacity or ability to use some DBT language, ability to use wise mind in those moments is really challenging. And so I think we can get really kind of involved for a long time in how to convince someone. But when the eating disorder has really taken hold, we kind of have to wait till that nourishment phase completes until we can get someone really engaged. And so I would say if you have a relationship with someone and you have tried to really connect to that relationship and get them engaged, and you haven't been able to, that's not surprising to me if they're at that need for an inpatient level of care. So sometimes we have to get people involved who really care about them and really talk about, the reasons for the referral and things like that, and really talk about what might happen kind of from an intervention standpoint almost if they're not able, to get inpatient, especially if it's a teen, because families can often really get that individual there and get them help.
Excellent, thank you. Melissa, that was a wonderful presentation. We really appreciate your time. For those that are interested in obtaining a CE credit for attending this event, Please fill out the questionnaire. The link is in the chat box on the right. If you have further questions for Melissa, she has graciously agreed to answer those. You can see her email in the presentation. She has also shared that she would provide her PDF of this presentation to anyone who would like it by contacting her. And we would also like to thank Timberline Knowles, who has been a generous sponsor of Eating Disorder Hope for years. And we're just so impressed with their clinicians over and over again and what a great job they do. And you lived up to the reputation as always, Melissa.
Thanks, Jacqueline. Thank you for your time, and thank you for putting on this wonderful conference.
Yeah, you bet. We appreciated having you. All right, great. Have a good day. Thank you again.
Thank you.
Bye.